All right, let me share my screen. Theoretically. Aha, that looks right. All right, nice. All right. So sorry I couldn't be there today. It's summer camp season and it got tough. So I apologize. We'll be back kind of in the usual swing of things next month. But this is not March of 2023, and it is not April 17th of 2023. Sorry, I didn't change that. But what we are going to do, and I'll give you my usual disclaimer for our protected CQI process. But so the reporting system was down for Hartley. So we didn't have our usual set of runs. So actually what we're going to do this month is just review 4 recent trauma cases. We actually just kind of had a really good organic conversation with folks from the trauma program. And we were like, you know what, we haven't like had a dedicated like trauma run CQI session. So we're actually going to go through a couple trauma runs here. Our goal, as always, of course, is to do the best we can for our patients, right? And so we learn from these cases. There's a lot of really good stuff. There's some stuff we can probably learn from it, from a couple of these cases. Ultimately, again, with the goal of improving our overall system's performance, not to lay blame or individualize really the care here. It really is to see how we can, as a system, rise tide, float all boats. And if there's anything systematic within our own structure, especially from the medical direction standpoint, that we need to know about to help you guys provide the best patient care that you can. Before we get into it, though, I want to introduce you to Dr. Alex Cheatham. She is our new EMS fellow for the year. So Dr. Connolly is now off in Wisconsin, Madison, doing a year of a flight physician fellowship. So she is on her way. We welcome Dr. Alex Cheatham, who has a very interesting background. I'm going to turn it over to you, Alex, to kind of give yourself an introduction to the group here. You'll be seeing a lot of her in person and around. And if there's anything of your bio that I find interesting that you don't mention, I will be sure to mention it now. But I'll turn it over to you for a quick introduction, Alex.
Awesome. Thanks, Dr. Richards. Hi, everyone. I'm Alex. I am actually pediatrics trained. So I am a pediatric emergency medicine doc at Children's. I did my pediatrics residency out in Colorado and then just finished my emergency medicine fellowship, pediatric emergency medicine fellowship here in Cincinnati in June. And so I, up until now, have worked mostly at the Children's base campus, but I will be working more up at the Liberty campus. So we'll certainly be interfacing with you guys clinically there. And then I've done basically 2 months worth of shifts in the Westchester ER and UC's Westchester ER as well. So I don't know if there's anything else, Dr. Richards, that you want me to share.
No, that's awesome. Thanks, Alex. Welcome aboard. We've obviously talked a whole bunch already about Westchester Fire, and you guys are great to work with, and so we look forward to having you around for this year. For the group, Dr. Cheatham's background is cool in that you are a pediatrician by original training, and then did emergency medicine on top of that. And what I think is nice for us up there is that what you mentioned in terms of having already done actually a fair number of shifts at Westchester Hospital, but also Children's Liberty as well. And so kind of your expertise in the pediatric side, in addition to the pre-hospital EMS medicine side more generally, I think it's going to be really, really nice for us this year. So welcome aboard. All right, so I kind of mentioned this a little bit in terms of our overall game plan for today. We're just going to look at And honestly, we probably won't take the whole hour, to be honest, but there were a couple interesting trauma cases, more so from probably the follow-up, although some of these have some pretty clear on scene interesting components as well that we'll look at. And honestly, these are from the past. One even goes back, I think, to Halloween. And we've reviewed a couple of these in different venues. So wanted to pull out a couple ones to highlight, just we haven't talked about quite yet. So thanks to Lauren Duffy, who I know is there, Jenny Brodsky from the trauma program at Westchester Hospital, Aaron Warder also pulls some of these data. And then I don't know if we talked about this or not, but at least on the doc side, the trauma program had a physician leadership change. So Ryan Ernest for the last couple of years did an awesome job. Still kind of around in certain capacities. Remember, he's active duty, so does get deployed. Dr. Aaron Seitz has taken over as the physician medical directorship and has been awesome for the last couple of months in that role. So we will see him, and thanks to that whole group for reviewing cases and sending us some of the follow-up and the information. Lauren, before we launch into this though, I do want to make mention of the trauma conference next month. So I don't know if you want to say a quick word about that. Just make sure that you're mic'd up here for the rest of us.
All right, sorry, we gotta hop off mute. All right, so August 22nd, we are holding our second annual Westchester Hospital Trauma Symposium. So basically what this day is, it's a 3-day trauma CEU. We have about 6 to 7 different lectures, which includes, I think we're doing mangled extremities this year. We're doing roll trauma. We're doing spinal trauma. We're doing something about whole blood. So about blood loss. And then we have an hour long for cases. We're also doing like emergency airway too. One of the doctors who was on the field with Mark Hamlin will be there. And then in between the lectures, we do skills stations. So these aren't like test out stations. They're basically just for you guys to practice skills. So we'll do needle decompression. We'll do like a pediatric stim with pediatric medication review. We do teapots. We'll show you guys how to do how we do fast exams in the emergency department. I'm trying to put other stations that we have. I think we're doing burns. We're doing emergent airway, like intubating in a car. It's all kinds of stuff, and it keeps evolving. So August 22nd, 8 to 4, it's at Butler Tech, the public safety campus over there behind the 111s. Free. I sent Hanauer and Hartley the registration flyer. We would really like to have a representation from Westchester Fire there, because most of the cases that we go over in the case review are your runs anyway. So we'd love to have some input from you guys too. So anybody have any questions about the day? Please sign up. Seats are limited. I think we're at 110 people already. We usually like to cap around 150. So seats go fast. Cool. Thanks, guys.
Cool. All right, thanks, Lauren. We will stay tuned for that. Last year was the inaugural one, and it was packed. It was a really good conference, and so on the heels of that, looking forward to this year's as well. So very cool. Thanks. All right, so let's get into cases. Like I said, we're going to do 4 of them. This is the first one. Again, if anyone's kind of new to this, I like just putting up your own documentation so we can kind of read through it, see kind of what your thought process is. I tend to highlight a couple of the things that I like to highlight, and then it ends up being kind of like a jumbled mess like this page is, but provides us with some conversation. All right, so this first one was a 91-year-old in an MVC, heavy front end damage, and it's good to kind of note that. We actually had some mutual aid on scene as well. I think because it was 2 cars, I forget exactly where it was. Patient was in the driver's side. There was a clear and obvious deformity to the right leg. was restrained, and the patient herself denied head, neck, or back pain. Airbags did go off commensurate with the mechanism. We did a nice job of kind of being mindful of selective spinal mobilization. We had a C collar, and then kind of was able to lower the patient to the backboard for extrication and then onto the cot. Vitals were okay, as you can see down there at the bottom. Actually, really good vitals. Blood pressure and pulse actually were pretty good. A little low on the diastolic, so we'll keep an eye on that. But yeah, she's actually doing okay vital sign wise. We also have to be mindful, of course, and just as an aside, of heart rates, especially in elderly patients, just because they may have some concomitant beta blockers, other antihypertensives that may have some effect on heart rate, especially if the patient otherwise would need a compensatory tachycardia and then they are blocked from doing so with their medication. So we'll keep an eye on that too. We did a head-to-toe examination, so really good secondary survey. We found some discomfort actually in the abdomen, and especially for cytosphilus MVC in anyone, but especially in the elderly, we want to be particularly mindful of that. There was actually some injury. It seemed probably more superficial to the left side, but the right leg was pretty obviously deformed. We're concerned about a femur fracture given that. We documented that thought process, which is really nice. But importantly, we wrote down the neurovascular status with the pedal pulse dystole, so great. We also found in the head to toe a little bit of chest discomfort, maybe some hip discomfort on that same side with the deformity. Started some IVs, gave some pain control. So thank you for doing this. So, you know, obviously we have a deformed leg, and we gave an adequate dose. So 100 mics of fentanyl for a clear fracture of this leg, like absolutely. Even though she's 91, still has opiate receptors, still is having a fair amount of pain. So go ahead and treat that pain. You know, keep an eye on that blood pressure afterward and all the rest, but like, let's make her comfortable and get her pain controlled, especially if we're doing kind of all this in and out. Important, of course, to note, in any kind of trauma settings, whether they're on anticoagulation or not. She was not. We reported that. And then we went to trauma 2. So here are kind of the injuries that we saw. I don't have her x-ray, I'm realizing, but you can see just from like the external injuries themselves, deformity of basically the knee there in the lower. So I think I have a marker here. So the knee, kind of the tib fib, so like the kind of more toward the ankle here, and then the left side as well. So basically significant injuries on both sides. And that's when they kind of, with this information of like the multiple injuries here, that's when the trauma team got involved at Westchester. But in addition to just these obvious injuries, ended up going for CAT scan and had all of this. So, I do have her x-rays. That's the next slide. All right. Well, anyway, so with all that, here's what she has. So she had actually a small hemopneumothorax, had a sternal fracture, pulmonary contusions. She actually had P's, interesting enough, rib fracture. So she has all this like chest stuff that we were able to at least identify with like our palpation of the chest walls and discomfort. Actually had a little bit of bleeding actually into the belly. So she actually did have some bleeding around that kidney, whether that was truly the discomfort that we were able to palpate or not, because renal injuries, I don't know, it's buried pretty deep in the retroperitoneal space. You think more abdomen, you think like intra-abdominal stuff. But regardless, she had that. She had a retroperitoneal hemorrhage, lots of orthopedics and spinal things. None of this was like compromising spinal cord, but she had enough. She had like pelvis fractures, hematomas associated with it. Here's her x-ray. Truly was a through and through like mid shaft fracture with angulation, and that's what we were seeing with, you know, kind of her deformity of her thigh. So a lot of, and you can even see on the x-ray though, tons of swelling, lots of deformity. This is concerning, obviously from an injury standpoint, but also in terms of potential blood loss area. She did have a sternal fracture. We did see a fast exam that turned positive, but there was no source for them to go after. So she actually did get a blood transfusion. They actually did put this in tracks and splint. And I'm okay that we didn't do a such on scene. Our Southwest Ohio protocol really does not incorporate it a ton, but even, you know, if you think back to your original thought process, if you have like multiple potential injuries in the hip pelvis, bilateral, it's very reasonable to stay away. And so I would have, again, stayed away in this situation as well. Once we kind of know what we're dealing with, and they went ahead and placed it because she ended up going down to UCMC. Now, to be perfectly honest, like they probably could have done a fair amount of what she needed from a trauma care perspective up there at Westchester, just kind of looking at her set of injuries. But the ortho stuff just ended up being a little bit much. So this is a perfect situation where like 100% I would go to Westchester with this one as the crews did. And then kind of sort out from there, do some stabilization, start the blood transfusion. And then it was just, there was so much like ortho and being 91 that they wanted her down there. And she actually did like pretty well. She got her femur fixed. She went to Chesterwood. And actually she is doing like very well. She had a follow-up in clinic, and everyone says that she's like doing really well. She had some like a hand injury, that hand surgery I think is still following for her. But like her wounds are healing up really well. She's getting around, and so she actually ended up doing quite well. So nice job on that one. Just to kind of bring this back into our own protocol, this in particular is kind of where I'll highlight. So we know that the overall trauma assessment gives us a lot of guidance in terms of mechanism, anatomic criteria, all that's measured, that's modeled on the field trauma triage guidelines. But remember that there is the geriatric trauma guideline. And I'll point out specifically this line 5, which is where she falls under, which is the known or suspected long bone, especially proximal long bone fractures in an MVC. So it was almost like exactly like where she kind of falls. And remember, and you've heard me talk about this before, and I'll say it again, when it comes to trauma, what I want you guys to do in the field is to recognize trauma center need. And what that means on the hospital side in terms of activation is up to the hospital. There is a ton of overlap in that Venn diagram, right? And so like there's a lot of overlap in terms of what you guys bring to the trauma center versus what the hospitals, what they end up doing in terms of, you know, having a trauma surgeon come down in an expedited manner, finding a trauma bay, these sort of things. But as long as we're making sure that we're aware of kind of reasons to go to a trauma center and conveying that on that radio report, that's what we ask of you. And that's exactly what happened in this situation, right? And so obviously they went to Westchester Trauma Center largely for this degree of injury, but also I think there was some mechanism involved, which was good too. So especially in these geriatric patients, as we'll see in another case, spoiler alert, always good to have a high index suspicion. Alex, Lauren, do you have anything? Or Cruz, if you guys remember back, I forget exactly, it was a couple of months ago, but anything else to report? She's doing really well, and she did really great. So nice job on that one. All right, so we'll go on to the next case. This is another good one. This is a good just kind of reminder of overall trauma with kind of an unusual diagnosis at the end of it. So it's a 23-year-old, another MVC, another heavy damage. This one again, getting plenty of leg pain. This one was on the left side. Always good to make mention of GCS, right? It was a high mechanism, so about 50 miles an hour. Airbags are deployed, heavy front end damage. The patient himself was actually still entrapped in the vehicle and needed extrication. But even before that extrication point, the crew went in, took a look, asked about neck pain, asked about kind of localized pain where the patient described really was focusing on this left leg, which we confirmed as having significant deformity. Now, one thing that I will say just from a documentation standpoint is while this is 100% accurate and true closed tib fib fracture, I do usually stay away from kind of like talking about fractures and diagnosis until I have that information. I really think the deformity is probably adequate. That said, what I really like about this is closed, right? And so we know it's not open. Alternatively, maybe complementary, if it's an open fracture and you see bones sticking through, well, no reason not to write down fracture. But sometimes in these situations, just in my own documentation, I sometimes talk about the deformities, and then later, kind of in my more medical decision making, I kind of talk about fractures and these sort of things. But anyway, that's pretty split hair. Again, great to give fentanyl. And the nice thing here is that because the access to the patient wasn't all that great, we used the alternate route of IM as we were kind of thinking about putting vacuum splints on and doing extrications and all that. So, and a lot of that I think harkens back to kind of some of the entrapment simulations that we've done, which is to emphasize like, hey, let's start that medical care while the patient's still entrapped, while we're doing the extrication. So that's reflected in this, and really nice job giving some pain control as we're kind of getting things even kind of ramped up. Now, the other thing I like in terms of this documentation is, and of course the patient care that's reflected in the documentation, is talking about how we were trying to get that vacuum splint on this deformed extremity, but still kind of pinned underneath the driver's column. So, you know, you put it on as best you could. We had some immobilization, both for pain control, but also stabilization of neurovascular in the bones. Put it on, and then we're like, all right, we'll reassess this once we get the patient out. So both in terms of like a thought process, not letting this leg kind of flop around and whatnot as we're getting the patient out, but also try to give a little bit of support. Really nice job. Now, that said, once we were able to assess, the pulse was good, the motor function weak and good to report. Who knows why that is, right? Could that be a spinal injury? Could that be a tendon laceration? Could it be related to, you know, the fracture itself? Could it be related to nerve? It's like, who knows, but good to have documented. With the fentanyl and the splinting, we improved some discomfort, at least from a 10 out of 10, which is good. Got the patient out on a backboard to get the patient extricated. Once we were able to do that, then we got our IVs, give some more fentanyl, and then started transporting to Westchester. So here's kind of the ED side of it. There was a little bit of a delay in kind of when the patients got from the ED to like CT scans, and probably that's because the patient went to a pod room. Probably that's reflected in, was there any true like hard and fast reason aside from like kind of a bad looking leg for the patient to have been called in as a trauma? And I mean, I don't know. I mean, it's hard to call an isolated leg deformity, you know, call that out in advance if you've given all the information to the hospital pre-arrival. But there was probably a little something there, but that gave that patient a little bit of time of observation where the CAT scan did diagnose some things. So it was a liver and a spleen laceration, and then there was this hyperdense fluid in the pelvis, probably a little bit of blood coming down, a contusion in the abdominal wall that's consistent with a Morel Lavallée lesion. Put a pin in it. We'll see what that comes back at, because I have a little slide, but we'll just we'll just make mention of that. The good thing, and probably honestly being 23 helped significantly. Patient held their own in terms of hemodynamics. Trauma came down, saw the patient, CT scans and all the rest, and then actually went to the operating room. Here's what the leg looked like. And that was a pretty clear fracture. No surprise. That got pretty fractured. Here's what the CAT scan looks like. So I don't have a slice where it shows some blood around the liver and stuff, but that's fine. But here's again the abdominal wall, and actually this ended up being kind of the bigger issue for him as it turned out. So this is that Morel Lavallée lesion. So anytime you see like that white kind of bright stuff in the right setting, and for these CAT scans, this is what it is. That's a bunch of blood. So there actually is like all this like blood in the abdominal wall. And while it's not like shown really well here, there's actually like active bleeding. Maybe this is actually right here, but anyway, it doesn't matter. Active bleeding into these areas. So most of the time, I mean, you can have some bruising, and you know, it is what it is. We think about seatbelt sign. We look for that bruising on the abdominal wall and chest wall when we do our head to toe exams. But sometimes you can actually have a shearing injury of a perforating artery that can lead to like significant like blood collection into the abdominal wall. It's pretty rare, but that's actually what ended up happening. So they ended up taking the patient to the operating room, doing an exploration actually ended up having some bowel injuries in addition when they actually got in there. And that may have actually been more the pelvic fluid that they saw. But they took a little bit of the ball out. They were able to kind of reconnect it. That's fine. They took a little bit of the omentum out because you can have just like really bad bruising, and it ends up being just kind of like an infection. Nitis, they cut out a little bit of that protective tissue, that omentum. And then they kind of went and did this IND of this bleeding in the abdominal wall. And then ortho, of course, fixed his leg. He actually did well. He stayed about a week in the hospital, all up there at Westchester, went home. And then actually, I was just looking at his chart a couple of weeks ago from the abdominal perspective. He's doing totally fine. Pretty much he's discharged from trauma. He had a little bit of a delayed wound healing, but that's since resolved itself. And then he was seen in ortho, and he's like, hey, he's doing really well. He's walking around, he's back to work. You know, a little bit of irritation where they had to, you know, fix up that shin of his, but he's actually doing really well. So nice job on that. All right, so here's this Morel Lavallée lesion. So basically what happens is, so you can kind of see the different layers there underneath the skin and the soft tissue. You have these like little perforating arteries that kind of come up. And what can happen is it's basically called an internal degloving injury. So similar to like, you know, how you get, you know, the hand stuck in the industrial machine and, you know, kind of skin just literally comes off. Well, same thing here, whereas like the skin, in this case of the abdominal wall, kind of goes one way and all that subcutaneous under it just goes the other way. So you have those shearing, perforating, like middle little arteries that kind of come up, and you can just get this like huge hematoma that happens here. Now, sometimes, especially if it's like, you know, not that like significant of an injury, like, or incidentally enough, the casket happens like seconds, you know, after they hit the door of the ED. Sometimes these things don't actually accumulate and they can be missed. And the bummer is that you can actually lose like a fair amount of blood. Like this one looks to be like a leg, which they can happen also. And actually you can have a fair amount of hematoma collection, therefore actually lose a fair amount of blood. But also, like if you don't recognize these, is that you can have like a ton of soft tissue necrosis. So you can get like the skin overlying can become ulcerated, even deep things can happen and get infected. So that's why they ended up doing the incision drainage, get all that hematoma out, let it heal up. They put like a compression dressing on it and like was on their way. So it's not, I mean, from our perspective of like a pre-hospital care, like you don't do anything differently, but like it's still an important kind of at least physical exam portion. So if you're seeing a fair amount of bruising, obviously we're thinking about deep injuries. especially if it's a seatbelt sign, you're thinking about internal chest and internal abdomen injuries. If you see it in the extremity, you're thinking about like underlying fracture. But in and of itself, reporting out those areas of bruising, especially if they're rapidly increasing over even your short transport time, like that might end up being kind of an important finding, and it was in this situation. So, but anyway, he ended up doing really well. Again, really nice job on that one. Any questions, comments, concerns on that case? Anyone who was there or any of the others? There? All right, that was a good case. All right, so case 3, this is a pretty complicated one. So this is a 80-something year old who had a pretty complicated presentation. So we were called out for a fall and initially altered level of consciousness. It was the morning. He had gone to the bathroom, was walking to his bed, not in a typical story, of course. But essentially on his way back, fell forward, landed on the edge, kind of got trapped between like the mattress and the bedpost, which is kind of a bummer. And he was very clear, that he was not able to get out of that situation. We had to help him out. But also was like lightheaded and felt weak before this all happened. So he was still technically entrapped when we saw him. He was weak, and whether that's a generalized weakness or a focal weakness, who knows? He's wedged between a mattress. Now we were able to get him onto his back. We were trying to do some spinal precautions at that point. But this entire time we were with him, we just said, feels lightheaded. He was very nauseated. We pick up on this multiple times in the documentation. Turns out it gets carried over to the ED as well, but was very lightheaded, was nauseated, vomited, I think, several times. And again, highlight a really good thing here, which was maintaining the airway while this vomiting is happening. So roll to the side, make sure the airway is maintained. Now, one thing I do want to make mention, just in terms of kind of consistency of thought and action throughout, is kind of the spinal precautions in this situation. 100% really like the idea. 80s plus year old person with any kind of fall, ground level, otherwise, who knows exactly what happened, has some weakness. We think about spinal precautions, and in fact, we rolled to the side during airway. But then just be mindful of kind of how the spinal precautions translate into a stair care for conveyance purposes. Now that, again, I mean, this person may be 3 stories up and this is our only way down. But if we have to do this in the context of someone who we've already kind of thought about and have already done spinal precautions, either we kind of think about, all right, once we were able to kind of get him out of this extricated or this entrapped kind of state, we took a look again. He had no C-spine tenderness, he had no focal weakness, he was able to range. Or we talk about how we were able to maintain spinal precautions like in this conveyance method, which is probably a little bit tough in a stair chair, to be perfectly honest. But we just have to be mindful of that. Again, this patient is vomiting all over the place multiple times. Do we recognize it? And so it must happen, 5 or 6 times, but then we transport. So here's kind of some more of the objective stuff. So vital signs, blood pressure is a little bit soft, but not frankly hypotensive. 105/54. The initial GCS was 13 in this situation. On repeat evaluation of the GCS, it came up to 15. Has pretty extensive medical history, cardiac and otherwise. And so again, we're thinking about for like between pacemaker and cardiac stents and even diabetes. When we think about that lightheadedness, then we're going down a syncopal evaluation. So did a medical syncope lead to a trauma fall? And then I forget exactly what the extent of this ortho back surgery was, but we, especially in the context of weakness and falls, we're thinking, we have all this back stuff going on, so you want to be particularly mindful of that. Now, in the context of all this, and I think it was well, for his cardiac reasons, was on Eliquis. So we'll bear that in mind. He did not take the Eliquis earlier that day, but was therapeutic and had taken, I think, at least the day prior. So of course, anytime there's trauma and anticoagulation involved, you gotta be mindful. Now, not to say that, like, you trip and twist your ankle, not like we're calling trauma stats necessarily on that, but if it's, head injury and we see bruising on the head and these sort of things, then we want to bear that in mind. This is our exam, in fact, in terms of what's documented. It's a pretty bland exam that's documented. I do commend at least the thought process of kind of going through Cincinnati stroke scale. It was non-conclusive, but at least we kind of have bore that in mind. And partly this is to kind of get to probably better characterize what that weakness the patient was experiencing, endorsing, and what we were kind of saying. But what we're able to see is that there's spontaneous movement left and right, although again, not conclusive on the Cincinnati. No evidence of like bruising around the head, although it's not documented as such. Any potential kind of trauma stuff, and again, hard to know even if at this point if this patient was even going down a trauma pathway, to be perfectly honest. But just be mindful of that. All right, so a little bit. So here's what happened in the emergency department, and I'll kind of bring through kind of what I think kind of happened from their perspective. So initially, the patient was fine, ground level fall. Who knows what happened? They decided to call the trauma team just based on the Eliquis alone, and I'll tell you that again, even this same presentation, I told you kind of my thought process on kind of hospital versus pre-hospital, pre-notification of our trauma team. They did it because the patient was on Eliquis. That's totally fine. There's always easy discretion involved. If you kind of put your finger on our hospital activation criteria, again, this is informational purposes only. This is not anything other than that. But theoretically, there has to be some sort of like sign of trauma in addition to the Eliquis, where our the big poster in the room said that we should do this. So I think they were probably casting a broad net with the patient being on the Eliquis, because I don't think that they didn't document any kind of head injury or bruising or anything like that either. But just to have put that in, they were actually going down a little bit more of a, could this have been a stroke that led to the fall? So they were kind of initially a little bit more along the lines of, could this be a medical leading to trauma? GCS was 15 for them in the emergency department. They did say this lumbar back pain. Who knows if it's old or new, but they were cognizant of that as you guys were on scene. This vomiting keeps coming up over and over again because patient was vomiting in the ED. And it sounds like during their head to toe, they were like, we actually think that there probably is a little bit of asymmetry to the right versus left. And like I said, that's kind of what led them down that calling stroke team. Now, I'll tell you that with being on the Eliquis, they're not going to end up being a tenecteplase candidate, and for a variety of different reasons, as we'll find out. Definitely did not, but they were at least kind of going down that pathway, at least to the extent that they did some like CT angios of the head and neck looking for a large vessel occlusion. But turns out the patient actually did have a fair amount of injury, and which is, I think highlights a couple things, which is even with like a ground level fall, especially if they are octogenarian or above or even less, but especially with our elderly patients, ground level falls, bad stuff can happen. And then you add the Eliquis into the mix there too. So there was a retroperitoneal hematoma, and this actually ended up being, from a hemodynamic standpoint, actually significant, especially with being on the Eliquis. There was a small subdural hematoma. I will tell you that I looked at the CAT scan myself, and boy, it was super small. But again, being on the Eliquis is going to be important. There actually was a L2 fracture, and it actually there was a little bit of distraction, kind of pressing on some of the discs. Hard to know exactly if that was kind of pressing against cauda and nerves, and the spinal cord ends by L2, but you kind of have your conus and cautequine and these sort of things kind of at that level. And so was it producing any kind of neurocompromise or not? Who knows? This is not his first rodeo. There's some chronic rib fractures there too. But then, so he goes off CT, everything's fine, got those findings, we're starting to get results back, and then kind of the Eliquis takes over and the retroperitoneal hematoma takes over and the patient kind of falls off a cliff. So you can see that kind of blood pressure is starting to get a little bit soft and then frankly hypotensive with 60s and 50s systolic. Trauma bay. Then they actually initiated massive transfusions. So they started not only pack red blood cells, but there's FFP in here. I think platelets maybe eventually kind of get involved. PCC is one of the options of reversing Eliquis. There actually is a another like Eliquis specific. It's basically all the DOACs except for Pradaxa, which we don't really see anymore. But for the Eliquises of the world, PCC is an option. And arguably could be a second option, but it is an option. It's far more easily stocked. And so maybe they just wanted to reach and grab for something really quick in the context of this like actively like decompensating patient. But got a lot of blood, a lot of units got reversed, and the blood pressure tends to ended up stabilizing a little bit. At that point, with this kind of stuff going on, they're like, we probably need to get this patient downtown. Because ultimately, with the active extravasation from like a lumbar artery, that has to be stopped. And to be perfectly honest, the best way for that specific injury to happen is just for the interventional radiologist to go in and include the artery. And so that's kind of what they ended up doing. Got some calcium. We've talked a lot about calcium at points along the way. Multiple reasons, but actually, and the reason we usually talk about in our setting is if there is a way to kind of augment that blood pressure a little bit, you can do it with calcium. But also once you start getting like multiple units involved, you start, you need to actually replace the calcium because it does end up binding. And so you end up, they got that. They did go by air care downtown. And the patient actually ended up having kind of a complicated course. So they ended up embolizing that lumbar artery, but then kind of the patient just ended up not doing very well. Had respiratory failure, got intubated, had every complication you can imagine. The bowels kind of stopped working, renal failure, liver failure. Although incidentally enough, the MRI did not show stroke. Knows exactly what that right side of weakness was, but the family ended up transitioning to palliative care eventually. And it just kind of goes to show, I mean, there isn't a ton of reserve for these elderly patients when they have even minor, what seems to be a minor mechanism, can be a major injury, can then end up being kind of a prolonged course. So the couple things just to mention here, and something that got picked up was, again, initially, your all's assessment there on scene, both between the vital signs and in this situation is a good example of it, of the GCS. So that GCS of 13 was the only time until he like fell off a cliff where the GCS was abnormal. And, you know, whether that could have been an opportunity or not, who knows? But, you know, if we're thinking even like a minor trauma, Eliquis, it was a GCS initially, you know, maybe that does end up changing things. But it's also important to kind of note that even if there isn't like a bruise or frank head injury per se, especially in the elderly population where you have those bridging veins, you can still have subdural hematoma. Now, like I said, I think it was pretty small, could have been meaningful though. And it probably was from a little bit of that bridging injury, either that it was there from a previous fall, but still it is worthwhile to mention that you can have subdurals even without even hitting your head, to be perfectly honest. I really like how we're thinking medical event leading to trauma event led to a broad differential in the emergency department, didn't pigeonhole any kind of subsequent thinking, which is really important. And kind of like one led to the other. And we've talked a lot about the geriatrics and Eliquis. So I think some potential opportunity there, but it's the learning point here, I think, is just be wary of those geriatric patients on anticoagulation because bad things can happen, even in the subtle presentation way. Any thoughts on that case? All right, so our last one is going to be really quick. It mostly is just kind of a awareness because it's a burn case. Lauren, maybe at the end you can talk a little bit more kind of about the upcoming kind of movement in burns at UCMC, but with Shriners moving up to Dayton, we the UC Medical Center folks have gone through the ABA burn certification. Is now a true blue certified. I mean, they've always been providing really good burn care, right? But now they are fully certified. So it's a burn case, and this is obviously a pretty sad and unfortunate case, but this is a structure fire, and the patient was extricated and really was critically ill. So there was 80% burn. Patient was unresponsive, but a couple of things here to really point out as really positive patient care decision making is, and we talk about this all the time, right? But the partially obstructed swollen airway with burns and smoke inhalation. So this is right away, not the 15-minute transport to the trauma center. It is intubation there on scene, which is exactly what we did. It helps obviously when their GCS is 3 and maybe our hand is forced a little bit, but just to highlight our airway assessment of significant airway burns, we are trying to jump on that as quick as possible and did 100% that. So nice job. Vital signs, because the vital signs themselves actually we're doing okay. Blood pressure, pulse, otherwise, but patient's unresponsive, and we have all that airway stuff. This is really a pretty it's a fast moving scene, a lot going on. This was kind of the assessment that we did on scene, and then really, I think, moved quickly to transport, which is very appropriate. Patient was critically ill on arrival. SATing 93%. So especially when intubated and we have 100% FiO2 and we are controlling the respirations, that is highly concerning for lung injury, of course. Just be mindful of a couple things here. Make sure end tidal is on. It was, but continuous end tidal the entire way. And then, especially for, even if the patient is initially unresponsive, thinking about pain control, and they very well may have, and it's documented elsewhere, but just anytime we're intubating the patient, obviously that's a lot of pain just in the oropharynx, but I mean, with 80% burns, that's going to be very painful. So even if they're not seemingly responsive, in my mind, let's do some fentanyl on these patients as well. They ended up getting the fentanyl as well. But part of the reason I say that is once we actually ended up getting oxygen in the patient, their GCS actually did improve. They had some spontaneous movement based on that GCS. So we'll keep them comfortable. They ended up actually giving some cyano kit in the emergency department, which, we've talked cyano kit a couple times already, and we could, talk at length about cyano kit, but any unresponsive in the context of house fire, we're thinking overwhelming smoke inhalation, hypoxia, hypercarbia, but then of course thinking about carbon monoxide, and then thinking about cyanide toxicity. Ultimately, kind of and I think I mentioned this maybe a couple of years ago, kind of the two syndromes I think about in cyanide poisoning are either completely obtunded and peri-arrest or doing totally fine. This is kind of that peri-arrest situation. They ended up giving it, probably not a bad thing. I know that our access is very limited on scene, and that I would not have necessarily cracked it open for this, but if you had and it was there, then reasonable enough. They did the crew on scene, excellent job of estimating burn, because once you start going to the burn center and they're doing their percentages in more detail, they got the exact same number, which is awesome. No other injuries. The patient ended up becoming hypotensive, and then it wasn't a weather-wise, air wasn't going, but they had the physician air crew. So I think you guys know this, but just so that it's stated, even if the weather is really bad, that same flight crew can still come to the outlying hospitals and make that interfacility transport. So if it is something like this, where this patient is about as sick as they get, they can actually still have the air crew come to the emergency department and then kind of go down in a air care mobile care bus. It gives you kind of that physician level transfer, and then they can kind of make it. So if it still is like, and again, I know that we don't use air care a lot, and I'm not necessarily saying that we should do anything different than what we do, but if you find yourself in a situation where, like, man, this would be, something where I know that they're even going to need the transport from Westchester where they can get some stabilization in secondary, if at any point along the way a free hand opens up to notify air care, feel free to. I mean, even if they end up doing weather checks or kind of get things rolling, it does give them a heads up. Not to say that you have to, but if anyone would have thought in this situation, it can give them a bit of a heads up. So here's what we were looking at. Obviously significant burns, including obviously the airway. Patient got appropriate fluid resuscitation. There's a little bit of movement in the field of fluids for burns, but honestly, for our pre-hospital setting, if you end up starting crystalloid, that's going to be actually a good amount, probably by the time that they get there, if you're able to get access in the midst of all that. They get admitted to burn and ended up this was just too great of injury, and the patient ended up transition to palliative and died right away. So, again, give the patient the best chance that we could have. I want to highlight what I highlighted a couple times already: the early intubation, really good decision making on that case. The burns, we always think about the estimation. We do this a lot. Really, again, just because it's an opportunity to just think about your pediatric patient. This is obviously not a pediatric patient, but thinking about your pediatric patients and kind of how that percentage change, and think about your overall estimation. It really ends up being, once you're in the 80% range, though, it's like, all right, it was 81 versus 79. Cyano kit again. I probably would have done the same in the emergency department setting. I probably would have done the same in your all setting, in terms of just airway management, and get to Westchester. And we talked about the air background resources. So good case. I mean, that's a tough one, especially in terms of the way that the patient presented. They were in there for a while, but we really gave that patient the best chance. So, any thoughts on that case by anyone or anyone else? Lauren, do you want to say a word or two about any kind of the burn stuff that's been cooking recently, or is there not much needed to be said? I know you said that they're doing a little bit of burn at the conference, but I don't know if there's anything.
Yeah, not much
you want to talk about.
to add to that. So they did get their burn verification. So they are working as regular burn centers. So if you have a patient who you think needs definitive care at a burn center, and you're not in a township that we think you can go straight to in a good amount of time, we recommend that. But as always, Westchester is there as an option to stabilize your patient. I know you guys have had a lot of house fire patients in the last year, so we've gotten those patients down in a good amount of time. But just know that UCMC does have that verification, and it's willing to take any and all burn patients. I'm currently working with Chief Hanauer and our burn manager at UC to come out to do a burn training, kind of talking about cyano kit administration and kind of focusing on quick trick as well. Once I get some dates for him, we'll get that scheduled and come out and do 3 days for training. Anybody, go ahead.
Real quick, speaking of cyanide kits, is there any talk of Westchester adding cyanide kits to the drug bag, given that cyanide blocks the uptake of oxygen, so our BVM ventilations are not effective or as effective because of severe cyanide administration?
So currently, no, just because of the cost of them, they're insanely expensive. I will tell you what we're doing in the county. We're having a conversation in the county about how to get cyanide kits to our county departments. I don't know how that's gonna look like. I've literally looked at the fire marshal's office and the EMS state office for grant funding, see if we can do something, but more to come with that, just not directly.
Yeah, I would say we're definitely from a medical standpoint, definitely supportive. I think it's seen as certainly a limited resource, and so how to best deploy that. And Lauren, I like your idea of almost like a mutual aid regional resource kind of thing when it comes to it. There's sometimes some talk about, because I think last I checked, and folks can correct me if I'm wrong, but I think Air Care does stock it.
They do, they can.
Yeah, and I mean, from our township, you're going to be at Westchester Hospital before really Air Care's there. But if you're working on like a prolonged scene or something like that, I guess that would be another consideration, I guess, to think about too. But yeah, when it comes to burns in general, I mean, really, it's kind of, the stuff going on at UC is helpful to know, but it doesn't really change a whole lot of kind of our transportation.
Do you guys hear it?
Cyanide kits, no. So, and kind of to bring this up, the house fires we've had, they're multi-fatality or at least multi-casualty, right? So not only do we have multiple victims that we're treating at the same time, but we're also having a transport issue where we're having to call in multiple mutual aid medics. So our on-scene times to transport these patients are delayed, which is then delaying cyanide kit administration and delaying good oxygen therapy. So even if we could get, say, one on the battalion vehicle.
I will tell you guys, just for your information, I know that Free is gonna start housing a unit in their, I think in their district car, so just keep that in mind.
So they're getting it, Fairfield Township has it on their trucks, I know Fairfield City carries somewhere.
Yeah.
And I mean, not to, and this isn't a complaint, please don't take it that way, but Miami Valley carries sodium thiosulfate in every single one of the drug bags. So I understand its cost, but when we're talking about Narcan for structure fires, getting one or having the availability of having one in our battalion car with mutual aid coming, that gives us at least two on the scene. And it's not uncommon for us to have 2 or 3 patients being chucked out of windows on these fires.
Understandable. Got anything else?
Hey, Trevor, just have Hartley buy a cyano kit and put it in the battalion.
He won't do it because he thinks that it's a waste. Thinks what?
But then trying to convince Westchester Hospital to put it in every drug bag probably ain't gonna be the best course.
Right.
Fill a Ziploc bag and throw it on the battalion dashboard, but yeah, it'd be nice to have one on scene.
It's definitely, it's been a hot topic this past year. As the EMS council rep, we're trying to figure out any kind of solution that we can to help. More to come, hopefully.
Copy that.
All right, that's all I got. Anyone else? Cool. All right, well, good to see everyone. We'll see what comes up and we'll take it from there.
Thanks, Doc. Have a good day.
Appreciate it. Thanks, everyone.